Welcome to another EduMed video. In this video, we'll be going through the latest ICNARC audit data that was published on the 1st of May. This will be following a very similar pattern to the previous reviews, so it'll be interesting for you to have a look back over the previous videos to see how things have progressed, but I'll give you an overview of things as they stand now and what the progression has been. The number of critical care admissions as a total now is 9,801 throughout the UK, and this is purely looking at adult intensive care data. You can see that it's almost 1,000 increase on the week before that. But as you'll see in the later slides, there does seem to be a bit of a plateau now in the number of new cases that are coming about. It's still around a 50-50, those who die and those who are discharged alive. But interestingly, there are a number of patients who do seem to still be remaining in critical care, and that remains fairly static as a proportion. What's of great relief is the fact that that massive logarithmic increase in the number of cases that were being admitted to intensive care has not only stopped but has come down. And I think most of us in intensive care now have seen the number of intensive care patients on our units dropping down as patients either declare themselves as deteriorating and die, or those that then recover fully and get discharged from intensive care. However, as you'll see in later funnel plots, there are a number of patients who do seem to be staying in intensive care for a long period of time and are remaining critically unwell, requiring organ support and not being able to be discharged quickly onto the wards. In terms of the patient characteristics, they seem very similar to the last few weeks. The mean and median age both are around 60, and this does seem to be a disease that people in their 60s get quite severe and require intensive care stays. It also predominantly seems to be a male disease for those who seem to get severe disease requiring intensive care admission. Around 70% of patients in intensive care are male, compared to only 30% of females. If you compare that to the viral pneumonias from 2017 to 2019, where it was a rough 50-50 split between men and women. Thankfully, it still doesn't appear to be a disease of pregnant women, and the ethnic divide does seem to be quite stark now, and there is a government-led analysis looking into why patients of certain ethnicities are at much higher risk of developing severe COVID-19 infection than those who are Caucasian. But you can see, just comparing blacks, for example, between the COVID-19 group and those with just a bog standard viral pneumonia, you can see that it's almost 5 times as much, the 10.3% compared to only 2.8%. And a similar trend seems to be apparent in Asians as well. 15% of intensive care patients are Asian, compared to only 5.8% for the viral pneumonias. We talked a lot about the indexes of multiple deprivation, and if you want to go into a bit more detail about that, I'd have a look at my previous ICNARC video where I talked in a bit more depth about this indice. And nothing's really changed. Those with most deprivation tend to be at higher risk of developing severe COVID infections. And in fact, if we look at the mortality data, we see that people living in areas of the UK that are poorer tend to do worse. Now, again, there are analyses going into why this is the case, but multiple theories can be postulated, such as having more comorbidities, having poorer diets, having more incidence of diabetes, hypertension, hypercholesterolemia, potentially not having as many diagnosed diseases, then therefore not properly managed before they develop their COVID infection. The honest truth is we're not going to know till we have a bit more information and maybe some multivariate analyses and other more in-depth epidemiological and population studies, and those are all ongoing. I keep showing this slide just to show you that London seems to be worst hit and the rest of the country is much less so. Now, the reason I think this is important is if the lockdown was very effective, places like London, people live in very close proximity to each other, so even with the lockdown there may be quite a lot of spread. Whereas as you go further afield from the big metropolitan cities, you get much less population density, and therefore the social isolation policies may have worked better. The reason I think this is important is that as we release the stringent social isolation policies that have been instigated and are still ongoing, we may well see these values here starting to go up, but potentially those in London may not go up as much if they've already been exposed to a greater extent than the more sparsely populated areas in the north and east of England. In terms of the preponderance for males versus females, again, this is just showing in graphical illustration of the fact that it seems to be affecting men much worse than women in those that are coming to intensive care. And similarly, with ethnicity, does seem to have a higher incidence in Asians, blacks and other ethnic minorities compared to what you would expect for viral pneumonias or for the local population. I'm not going to go into too much detail about this because once the next multivariate analyses have come through, we can talk a little bit more about this. This is just giving the broad brush what it looks like, but we need to look at the confidence intervals and also look at some of the causative reasons for why this is the case. The index of multiple deprivation is interesting. This pretty much reflects exactly what we saw in last week's ICNARC data. And essentially what it's suggesting is that those at higher levels of deprivation tend to be overrepresented when it comes to intensive care. And that sort of makes sense. But again, there'll be more data looking into this in a lot more detail later. Looking at BMI, whereas the viral pneumonias, not COVID, tended to have a preponderance towards those patients that were of the lower BMIs, and that's why the skew seems to be more moving towards the left-hand side. COVID itself, which are the bars, seems to have a more equal distribution, and if you look at the population distribution of BMI, it seems to follow that fairly accurately. So it doesn't seem to have that same preponderance towards those with a lower BMI, like other viral pneumonias. When looking at those patients who are requiring advanced ventilatory support, this is intubation and ventilation or other non-invasive ventilations, what we find is actually the vast majority of these patients are of very good pre-morbid status. They're not requiring any assistance with activities of daily living, 92%. And actually it doesn't even really seem to be a predictor of whether these patients are going to end up needing advanced ventilatory support, because the vast majority of those patients who just require basic support have also got no assistance with daily living. But in fact, interestingly, there's a higher proportion of those who require some activities of daily living who get basic respiratory support. Now, we have to take this with a slight pinch of salt. We've got to be cautious about analysing this data because we're looking at a certain subgroup population. We are only looking at those patients who are being admitted to intensive care. So it may be that those who require assistance with activities of daily living are not actually making it to intensive care. And certainly with the frailty index scores, that does make it more difficult for patients to be admitted to intensive care if they do have a high frailty index, and therefore one would expect you wouldn't see so many people in these two categories. It's also interesting to say that there's a low number of patients who have other severe comorbidities. And the reason I think it's important to emphasize this is the fact that we're seeing such high mortality with this disease, and these patients are all those of actually fairly good physiological status before coming to intensive care. So if you would imagine that if you'd admit some of the patients with poorer physiological status, the mortality might be even higher in the intensive care data, which is all that ICNARC looks at. I think it's interesting to see how long people are staying in intensive care. Now that we've got a fairly long, robust data set with almost 10,000 patients in it, it is useful to see how long people are staying in hospital, specifically in the intensive care. And you can see it's about 6 days for those patients who survive with COVID. And that corresponds pretty similarly to that of the viral pneumonias that were non-COVID. Non-survivors, interestingly enough, are also taking about 7 days. And the ranges here are between 1 to 2 weeks. So this is not a disease that gets better quickly. And it's difficult to say how long these patients may be in intensive care before they declare themselves. In terms of organ support, you can see that the vast majority are requiring advanced ventilatory support at some point, almost 70%. And about 30% of them are requiring advanced cardiovascular support. What we've been noticing and emphasizing quite often is the fact, and quite worrying fact, that 23% of patients with COVID are requiring renal replacement therapy. So this is 23% of all patients being admitted to intensive care with COVID-19. That's a very high proportion, 1 in 5. Now, it's worth going, if you want to take a bit of time to look through the data in the tables that I've presented and pause the video, you feel free to do so. But it's worth actually being aware of what all the different parts of the tables mean. So I'm not going to go through this in any great detail, but they've expanded the explanations in this week's ICNARC data. So if you want to have a read, please pause the video at this point, and it'll go through some of the definitions for things like what advanced versus basic respiratory support are, and what very severe comorbidities are. Now, it's interesting just to see what the proportion of people who are surviving versus dying are for different patient characteristics. You can see here that if you're young, so below the age of 40, you tend to do quite well. And actually, in fact, below the age of 50, you tend to do quite well, with more than 2/3 of patients surviving and being discharged from critical care. But you compare that to the 70 and above age group, where 1 in 3 patients are surviving to be discharged from intensive care, whereas roughly 2/3 are dying in intensive care. And so, although age in and of itself is not something that we use to preclude someone from intensive care, it is worth for our older patients to actually have an open and frank discussion about the fact that a lot of the older patients do seem to die on intensive care. You compare that to the viral pneumonias, which is what we're much more used to dealing with, so the non-COVID viral pneumonias, where you've only got about 1/3 of patients dying at worst. So this has got double the mortality, more than double the mortality of the viral pneumonias for any given age, but especially for the older populations. Interestingly, it's even higher risk in the younger group with COVID compared to viral pneumonias. So this is a really deadly disease for those patients who end up on critical care. Although I mentioned that many more men are coming to intensive care with COVID-19 compared to females, once on intensive care, It seems to be relatively equal, the number of patients who are dying, whether they be male or female. Slightly less females, but 51% are dying who are men, and 42% of women die. So not that big a difference. Ethnicity, again, we'll talk in a lot more detail in next week's video, because we'll have some of the multivariate analyses at that point. I think the funnel plot is really interesting. And what we're seeing here is in the green lines, these are patients that are not requiring mechanical ventilation in the first 24 hours, i.e. they don't require intubation. And in the dotted line here, you can see those that are discharged alive, and on the thick line, those who are survived. So you can see that there's about above 70% survival if you aren't intubated in the first 24 hours. And similarly, a lot of these patients are being discharged from intensive care as well at 30 days post-intensive care admission. But you compare that to the patients who are surviving with who are intubated within the first 24 hours. You can say it's roughly about 45% of patients survive. So 65% of patients are dying in intensive care. So 55% of patients are dying in intensive care if they've been intubated in the first 24 hours. But what I also want you to note is the big gap there. And that gap represents those patients that are remaining in intensive care past 30 days. So not only are patients dying on intensive care, but also there's a large number of patients that are remaining on intensive care, with the number discharged being the dashed line being much lower, at only around about a little over 35%. So we have to think slightly carefully about the mortality and morbidity of these patients, and those that require advanced ventilation, if you want to put numbers to it, 62% die in critical care. You compare that to only 34% in the non-COVID viral pneumonias. What's also really significant is the fact that 74% of patients who are started on any kind of renal support die in critical care, compared to 46% of the viral pneumonias that were non-COVID. So there's a massive number of patients, more than 2/3 chance of dying if you get started on renal replacement therapy. And as we said, 25% of patients with COVID-19 coming to intensive care require renal replacement therapy. So it seems to be a very bad predictor of patients, and it seems to be a lot of patients who are getting renal replacement therapy. It's also interesting just to see the length of stay in critical care for survivors versus non-survivors. And you can see here the median is about 13 days in intensive care versus only 8 days for non-survivors. But look at how much shorter that is when compared to those patients just requiring basic ventilatory support. So it is interesting to notice, but also when thinking about the allocation of services, look at renal support. These patients need an additional 6 days in hospital, so much longer. So we've got to be really careful when you look at this, because these patients are requiring renal replacement therapy for much longer than, say, those who require just basic respiratory support. So those patients that we can keep without intubating may well do a lot better because they don't need renal replacement therapy. The difficulty here is whether it's because patients are much sicker, they require intubation, and therefore almost by extension they require renal replacement therapy just because they've got much more severe disease, Or is it the actual physical nature of intubating someone, taking over their ventilation, increasing their inflammatory state by giving mechanical ventilation, giving high peeps and reducing venous return, and causing increased myocardial strain? Could these be factors in making patients more likely to develop and require renal replacement therapy? The honest answer is we don't know, and we need much more data in order to be able to tell. But certainly food for thought. When looking at length of stay and organ support by comparing those who get renal replacement therapy and those that don't, again, much higher risk of death if they require renal replacement therapy. Now, I kept alluding to a few times the fact that in next week's ICNARC data we'll also have some multivariate analyses, and they're going to be really interesting because up until now all of this data we have to take with a pinch of salt, and we have to note the fact that we're looking at trends. Whether or not they're significant, we can't tell. But with the next multivariate analyses, hopefully we'll start to get a bit more robust data that we can analyse and apply more to clinical practice. So overall, this ICNARC data from this week doesn't really show any more new information in terms of patient demographics, those at risk, and what's happening. What I can say is that the numbers of new cases are dropping, which is reassuring. But we may well get a second wave when we open up the social distancing policies, especially in areas outside of London, where I suspect social distancing probably had more of an effect just due to a more widespread population. So it'll be really interesting to see that. Next week, what we'll also try to do, if we get the data, is to go through some of the PICU data, because we're starting to see a lot more patients, paediatric patients, coming to intensive care. We've talked a little bit about Kawasaki disease in some of my previous videos and the potential link, but also we're starting to see some children coming in with myocarditis. So whether that phenotype that we were seeing in adults, which was early being described in the Chinese data and the Italian data, whether we're starting to see that in children with the myocarditis, which, to be honest, I haven't seen much of anecdotally in my practice in adult intensive care. Maybe we're starting to see this in the pediatric population. So if you've liked this video, please like it, subscribe to the channel, but the important thing is hit the bell notification button, because then you'll be notified of the next video that comes out, and the next one's going to be really interesting because we'll be going through some of the multivariate analysis from the ICNARC data, and also hopefully adding in some of the PICU data if we can get hold of it. Thank you very much.